the first thing that I really want to make clear as a part of this presentation, that there is no doubt that women with diabetes in pregnancy are definitely exempt from fasting in Ramadan. So that's a really important thing that I first want to make very clear, that Islamic regulations provide that all pregnant women have the option to not fast if they feel worried about their health, about their baby, or if they feel burdened in any way by fasting in pregnancy. However, we know the reality is that many pregnant women still partake in the fast as they feel fit and healthy. And it's estimated that up to 90% of healthy pregnant women observe the fast, although many studies do suggest that they often don't manage the full month of fasting. Now, that's in a healthy pregnant woman. So adding diabetes to the pregnancy makes the burden that much more. And despite this, some women still choose to fast. So what do we know about what the Muslim women are thinking in terms of their perception about fasting in Ramadan, and what are they doing? Now, thankfully, in this space, there have been various studies looking at the attitudes and practices of Muslim women and what they're actually doing. So the first study I just want to highlight is the study done across 4 specialist centres in London in 2012. So it's a little bit of an older study, but still holds quite true. This was looking at almost 50 women with an average age of around 32 years. The majority of women had gestational diabetes, but almost a third did have type 2 diabetes. Of this group, just under half were diet controlled, a quarter were on tablets, and a third were on insulin. 10% of this group fasted during Ramadan, and of the women who chose not to fast, the interesting thing is that they had had a history of hypoglycemia, about a quarter of them. So a history of hypo seems to be a contributing factor to a woman choosing not to fast in that context. So she's had a bad experience. Women who were based rurally or immigrants or of lower education background were more likely to fast. And interestingly, although in the West they have this idea that possibly husbands might encourage the woman to fast, in fact, that was the opposite, and husbands tended to discourage women from fasting when they felt that they were endangering themselves. And we found that women were just as likely to consult imams as they were to consult health professionals. So as health professionals, it seems that we are placed in an important position and they will ask us for our advice. Looking on the other side of the world now, in the US, another study was done, published in 2016, looking at a centre in Detroit. And this was looking at women aged between 18 and 50 years, and they filled out a written survey on their perception of fasting and what influenced their decision-making and healthcare expectations. There was just under 40 women who completed this survey, and of those women, 70% did not fast in their current or most recent pregnancy. 2/3 believed that fasting was potentially harmful to themselves or their fetus or both, and a small amount of women in that cohort, so less than a fifth of women, consulted others about their decision to fast. And that could have been healthcare provider, family, or an imam. The most important characteristic identified within these women was that they wanted the physician that they spoke to be respectful of their Islamic belief and possess a knowledge about Ramadan, and that would make them more likely to engage with them in the discussion. Now then, bringing back to my side of the world, so I come from Bankstown Hospital, and back in 2014 I conducted a small study there looking at 30 women, and we surveyed the same questions, so attitudes, influences, and experiences in the Ramadan fast. So 29 women completed the survey. The majority of them had gestational diabetes. We had a small portion with type 1 diabetes. The average age was just under 30 years. Of this cohort, more than 2/3 had a higher level of education. And interestingly, in this group, almost 40% still weren't sure about the permissibility of abstaining from the fast. So that was a really important information for us to be able to put out to them. The other interesting thing was almost 30% thought that a finger prick would negate their fast. So that's really important, because if they chose to fast without discussing with us, then they would be less likely to self-monitor their blood glucose, thinking that that would invalidate their fast. And about half women said that they would fast with diabetes in pregnancy, but over 90% said that if they did not have diabetes in pregnancy, they would certainly fast. So having the diabetes was a real decision changer for them. And most women identified the baby's health as the major influential factor on their decision to fast or not. And about half of them identified their own personal health. In terms of what would influence their opinion to make a decision one way or the other, a doctor's opinion and an imam's opinion were equally influential, just like the study in London. So further to that, we did another study in 2016 at Bankstown Hospital, and this was 54 women completing the survey. Now, just for our audience internationally, just so you know a little bit about Bankstown Hospital, so this is a hospital in Sydney, Australia, so it's in the West, but we have a large proportion of Muslim women within our centre, and of those Muslim women, probably about a third is from like Middle East background, so Jordan, Lebanon, Egypt. So within that centre, we were still able to capture quite a lot of Muslim women, but it is looking at women living in the West as opposed to majority Muslim country. Of the 54 women, about a third of the cohort did choose to fast some of the time of Ramadan. On average, it was about 12 days. Some fasted as little as one, and there was one woman who fasted the whole month. And interestingly, about a third of the cohort who decided to fast were on insulin. So even being on insulin did not discourage them from fasting completely. But of those who decided not to fast, half of them were on insulin. Now, in that cohort, it was a very small group, so you really can't comment on fetal outcomes in that cohort. So that brings me to just really stepping back and remembering that a healthy baby does not just rely on 4 weeks of Ramadan, of what a woman does during Ramadan in that 4 weeks. And also, depending on where Ramadan sits in a pregnancy or before a pregnancy, can also affect outcomes for a baby. So what we really need to remember is that pre-pregnancy planning is important and pre-Ramadan planning is important. So it's really key that we get the woman thinking about her plans prior to becoming pregnant. So this is in women with pre-existing diabetes. So before pregnancy, thorough pre-pregnancy planning occurs regardless. Our obstetrician colleague and our endocrinologist colleague will vouch for that. It's a very thorough pre-pregnancy process, obviously depending on where in the world you're from, but anybody with diabetes has really got to be planning a pregnancy. Now, likewise, there should also be a pre-Ramadan assessment of diabetes control, a history of failure or success, all the factors that we use for risk planning for these women. And this needs to happen if we think that Ramadan is going to be falling during the pregnancy. And also, if a woman is planning a pregnancy and it could be Ramadan just before, then in someone, for example, with type 2 diabetes, we really need to consider and counsel in regards to ensuring they're aware of what the pregnancy targets are and likely need to be on therapies such as insulin or metformin prior to pregnancy, and that could happen during Ramadan, and therefore appropriate changes and planning needs to take place. So management of hypoglycemia, regardless of whether a woman has GDM or pre-existing diabetes, is going to involve a pre-Ramadan assessment, thorough education, and advice about activity and nutrition. And in the pre-Ramadan assessment, we know that women are not clear on exactly what to do, so this issue must be raised. Some studies, as we suggested, people get advice from family or imams instead of healthcare professionals, so we need to be in a position to provide that advice with pre-pregnancy counselling. And I think that they're generally a motivated cohort who can make an informed decision based on evidence that's presented to them. So in terms of the effect on healthy pregnant women who don't have diabetes, there's conflicting literature in terms of what fasting does for those. Some studies have shown that without diabetes, women can go into preterm labour, or they can have smaller babies or decreased placental weight. There's also been some studies to suggest increased triglycerides, increased free fatty acids and ketones, and possibly some change in cortisol, but nothing conclusive more recently. And that's in a healthy pregnant woman without diabetes. So what about women with diabetes? Again, the studies are very small, and there do cover studies with women treated with diet alone or metformin or insulin. And overall, there is a significant improvement in hyperglycemia, but there was an increased risk of asymptomatic hypoglycemia. So the study by Baynuna et al. Showed there was a high risk of 1 hour postprandial glycemia in pregnant women compared to their non-fasting controls during Ramadan. And the other thing is that when we looked at CGM as well as self-monitoring blood glucose, there was a lot of hypos found between 4 and 7 p.m. And this is a time where women don't usually do any self-monitoring. So this would be missed hypos. So this is a really important part of education. So informing the women of the risks to themselves and their baby, and then discussing the reasons and why they would break the fast if they were still going to embark on the fast. Ensure they're aware that they can finger prick, because you can't assume that they know. And show them how important it is that they do test, especially in some of that high-risk time in the afternoon. So during pregnancy, the targets remain fasting and postprandial targets. And if they are experiencing any symptoms of hyperglycemia, feeling unwell, reduced fetal movement, dehydration, or hypo, then they must be willing to break their fast for you to agree for them to fast safely if they choose to do so. If they're on diet or metformin, really the mainstay is monitoring their blood glucose and adjusting their diet, and then reassessing based on their blood glucose profiles. And exercise should still be encouraged, of course, but probably in the non-fasting time of the day. Insulin therapy would really need to be modified based on the woman's blood glucose results. And, it's not easy for women to fast with insulin. And again, I would reinforce that our recommendation would be that they don't fast. But if they still insisted on doing that, then you adjust it based on their blood glucose targets and reassess. So what about after the pregnancy? So we don't want to just end our discussion during their pregnancy. So lactation is a really important time and a really important time for increased energy consumption in any woman who's lactating. There was a study in Karachi, Pakistan, published last year that looked at almost 280 women and found that 82% of women were fasting during Ramadan when they were lactating, and more than half did suggest they had some difficulty, most commonly with thirst, hunger, and weakness. Most women were aware of religious exemption but still chose to fast. And there have been other studies that show between 40 to 80% of women choose to fast whilst they're lactating. There aren't any studies, as far as I'm aware, of women who are lactating and having diabetes, and then whether they choose to fast Ramadan or not. So that's an interesting space, and I'll be interested to hear if anybody has any further information on that. But what we also know about lactation and glucose control, in women with pre-existing diabetes, there is often a reduced insulin requirement. So we really need to consider the effect of lactation and make the appropriate adjustment to therapy, as well as the potential risk of dehydration, reduced breast milk production, hyperglycemia. Conversely, in women with a history of gestational diabetes, we know that lactation is really important in terms of potentially reducing their further development of type 2 diabetes into the future. So we would encourage lactation, and we would have to consider the effect of fasting in that cohort. So basically, to summarize, there remains insufficient evidence to change the high-risk status of fasting during Ramadan for women with gestational diabetes. Those with pre-existing type 1 or type 2 would still be considered a high-risk group and be challenging. Nevertheless, it is an important personal decision, and we need to take a practical approach to explain the risks to the mum for herself and her fetus, and help them to make an informed decision, and then support them to do it safely if they still choose to do so. And the mainstay of therapy is ensuring self-monitoring of blood glucose. If we have access to continuous glucose monitoring, to utilise that in our high-risk patients, and ensure that our education commences early and covers the entirety of pregnancy as well as post-pregnancy planning. Thank you.